For my single subject design, I chose the treatment of attention deficit hyperactivity disorder, ADHD, and I went with Tina from the different choices we had, and Tina was diagnosed with ADHD, and for my study, I treated her with methylphenidate MPH and cognitive behavioral therapy. The study really was an attempt to add to the already large corpus of work on this topic, and it really tried to lay the foundation as the best practice for how social workers should treat children with ADHD. It's really an ideal type, not necessarily the most practical, which I can get into later with weaknesses of the study. Based on the literature, there is a lot of it. Different studies use different drugs, different treatments, different assessments, and different time periods. But they really tended to show that the best results was with the medication and therapy combined. My research question looked more at both the short-term and long-term effects of behavior associated with ADHD based on these two interventions. And, my research methodology was, I guess you consider an ABA withdrawal design. They were measured at the beginning of treatment using something called the Connors assessment, which is an ADHD assessment. It was done at the beginning of treatment, at the end of treatment by the parent and the teacher, and also 2 years later to see if it had a lasting effect. That was basically why I chose that. I wanted to see if it would have both a short-term effect based on their assessments, but then also a long-term. So the independent variables were the methylphenidate, the Ritalin, what do you want to call it, and the cognitive behavioral therapy with a couple of different additions to the CBT. And the independent variables was the Connor assessment, the CPRS, the Connor parent assessment, the teacher assessment. Some of the confounding things that I thought would be addressed was having shorter therapy sessions since the child was so young, getting her to focus for a short period, but having them more frequently. So twice a week instead of once, and 45 minutes instead of an hour and a half. And it was also really important that the continuity of the teachers was a part of it, so that at the beginning it was the same teachers at the end, and then making sure that if the schools changed or the parents moved, which is an issue with this family, that was a part of it. So the data was measured by the parent and the teacher's assessment, which they would take at the school. The assessment itself is shown to have high reliability and validity. So if a child scores above 1.5, it's very reliable and valid that they should be diagnosed with ADHD. Now, based on the literature review, and I guess maybe more common sense, I expect the results are that it will have a short-term effect on the behavior. You will see a reduction of the behaviors at school and at home. But that in the long term, as the formal supports go away, the effects should diminish. One of the studies in the literature review highlighted that if you're going to your doctor to get your medication, or you're going to a licensed clinician at maybe a PRTF or some place where they monitor your medication intake, and they make sure that if it's not working, they increase it or decrease it within a quick period. The literature says that really doesn't have a lasting effect on whether someone gets better or worse from ADHD. And literature also highlighted that once the CBT stops happening, the effects from the CBT tend to go away as well. So from a discussion and conclusion perspective, I think the biggest strength of this study is that it's in accord with literature and best practices, especially when it comes to measuring as well. And I think one of the big limitations was both the sample size, but also just subjective nature of assessments in general. could have more baselines also to measure if it's working quickly enough, so you could switch up the ADHD. I didn't use as an implication. And I think the paper, large implication is that for social workers, we think that once the formal supports go away, everything will be fine. But in actuality, once they go away, things tend to go back to the way they were, and that's a big issue that we could do a lot better at addressing, in my opinion. Social workers, we try hard and we work with families for a good period, but ultimately we leave and the therapists leave, and when that happens, the family's left holding the bag, and their situation may ultimately not be that much different. So, I think moving forward, when it comes to using these type of therapies, when it comes to using this medication, that we should encourage it, but we should really make sure that these kids, have the supports they need, both informally and formally, once the treatment is completed.